Thank you, Dr. Cohen. We appreciate those comments and your leadership. CDC seems to be trending all in the right direction under your leadership. Thank you. As we begin the Q&A session now, we invite organizations who have not already presented today brief updates on their health equity priorities and how they're implementing them to share them if you would like to. If you want to participate, please notify the event team through the Q&A button. You can provide your name and your organization's name to alert the facilitator that you want to present. And we'll let you know when it's your turn via the chat function and set you up to be able to turn on your camera and microphone to say how your organization is implementing your priorities in 60 seconds or less. We genuinely value our members' engagement in this meeting. That's what it's all about. So thank you. All right. Now we have a number of questions that have been rolling in throughout the meeting. They started almost immediately during the first panel, and a lot of questions to get to. Of course, if you haven't posed a question yet, you're welcome to continue to enter those questions. Please use the Q&A function at the bottom of the screen. We look forward to hearing what you have to ask and to hearing answers from our speakers today. And it's really great now to be joined by several of our speakers. And I want to kick off with a question for Drs. Manchanda and Taylor. What do you think about the concept and necessity of sustainability, both individual and community sustainability, as a component of, or as a vital condition for health and well-being? Rishi, do you want to go first?
Dr. Manchanda.
Thanks, John, and thanks, Lauren, for letting me take a first pass at that. And thanks, everybody, for the opportunity to join you all today. Really want to echo my appreciation for the organizers of today's kind of forum and for this meeting and for the forum in general, for all the incredible work you guys are leading. Sustainability. It's my first thought is, immediately went to was how unsustainable the current situation is and how part of our work is to make that more acutely felt by institutional actors at this point. It is unsustainable to have, and the amount of inequities that we have continue to persist, certainly for the families and people who are impacted most and harmed by inequities in health and healthcare. Certainly true for those families suffering with heart disease disproportionately compared to others. It's unsustainable for institutions to continue to apply business models of fee-for-service, for example, and other limited models that reinforce perverse incentives, right, that don't do enough to incentivize keeping people healthy and removing inequities. So my first thought is just that it's important first, I think, to share an understanding of how unsustainable the current situation is and do our best to be able to make that felt by institutional actors who may not feel the direct pain of those inequities or those poor outcomes in the way that they currently do, right? There's a reason that they've continued. It's because the business models have allowed them, the economic models, the policy models have allowed these things to persist. So that's my first thought. The second, on the flip side, is if it's unsustainable in the current state and our job is to help institutional actors that are currently benefiting perhaps from these inequitable outcomes start to feel how unsustainable it is. I think it's also possible for us to, within the vital conditions kind of framework, revisit what sustainability means, and first of all, do that by asking for whom, right? For first and foremost, people most currently impacted by inequities, I would put forward as the first group, communities that are right now strapped in terms of only having healthcare kind of resources rather than other social sector or public health resources to address the priorities that the National Forum and Dr. Cohen enumerated. And then, of course, the institutions within them, right? Healthcare institutions being one sector, one industry, but other institutional actors, other sectors as well. And I think if we can start to identify who sustainability matters for, then we can start to identify where there's some alignment in that way. I have some additional thoughts coming to my mind, but I'll pause here mainly because Lauren is way smarter than me.
Well, thank you, Dr. Manchanda. And I should have set the stage before just launching in here. We have a lot of questions to get to. A lot of people posed a lot of questions. So if we can try to keep our answers to 1 to 2 minutes, I know that's a challenge, but if we can do that, that would be helpful. That's not directed to you, Rishi, and your answer. That was just my having forgotten. Before hopping to Dr. Taylor, I do want to call out a couple of things that you pointed out. First, the role of perverse incentives. I think that doesn't get nearly enough discussion, and it's huge. Where the dollars go, where the gravitational pull of dollars certainly influences how not only providers perform their services, to whom they provide them, and what rises to priority for them, but it also influences consumer or patient behavior. A couple of people have made the point, they're not patients, they're people. So I think it's important for us to keep that in mind. Really appreciate your calling that out, Dr. Manchanda. Dr. Taylor, sustainability.
Well, it's funny. My brain went to a very different place from Rishi's, which was, yeah, sustainability. I'm so glad to see the natural thriving world as part of the vital conditions. So I went to a much more eco-sustainability place. And that was, I think, the thing that I said on the panel itself was the biggest kind of pleasant surprise coming out of this framework. A lot of it is in some ways rebranding old concepts, but I was like, boom, that's an exciting real step forward to see an organizing framework for our work in health that takes seriously the impact of healthcare delivery and related industries on the climate. I would just say to Rishi's point, a slightly, skunk at the picnic type comment. I do worry about sustainability and the idea that our current state and trajectory is unsustainable as a motivating factor for change. I've been around healthcare for 10, 15 years now. For the entirety of my time, people have been saying, oh, the trajectory of healthcare spending in this country is unsustainable. And you know what? The longer I stick around, the more I'm like, no one seems to care. It certainly doesn't seem to galvanize a tremendous amount of political will to do things differently. And so I guess I would just, while I agree always with everything Rishi says, add that the argument, we can't continue on this track record because eventually in 10 years or further out, we're going to crash and burn, has been an effective strategy to mobilize change. I think we need to make more concerted choice to say the current conditions are unjust, or they're unfair, or they're not in keeping with our civic ideals, and choose to do things differently.
I think you, Lauren, with that point, I think you just brought us back to perverse incentives, at least as one reason why people don't care. Rishi.
Yeah, amen. I think, Lauren, to your point, and the earlier point as well, which I really appreciate you kind of raising, which is the ecosystem sustainability perspective. 100% agree with that. I think I agree with you that there's that arguments around sustainability in the healthcare economic kind of space are ineffective because not only are they falling on ears that are not listening right to these arguments, but those ears are willfully closed because the perverse incentives, have direct benefits in the short term. And so the second part of my comment about sustainability that came to mind is making sure that those who are benefiting in the current system that is currently unsustainable for those most impacted feel acutely the power of that. And that will, to Lauren, your point, I agree with this. And I'm curious what your thoughts are on this, as well as others. I don't think that will come from within. I think the focus on equity, for example, in recent years, has not been because of some healthcare equity focus, I should say, within the healthcare industry, for example, is not a result of healthcare institutional leaders driving that forward. It's because of a response to movements and claims on justice, claims on power, right, that have necessarily put industries, including healthcare, squarely in the focus, right? And it is therefore unsustainable to continue on in the healthcare equity kind of space in the healthcare space without now talking about equity, not because of any volition of those leaders necessarily within, although there are many courageous leaders in the healthcare side, but primarily because of a response to movements. And I think that's the opportunity here to look at the vital conditions framework and identify the role of other sectors, including movement building organizations, advocacy organizations, as a powerful means to provide the wind to the sails here, to push, provide heat and not just light, right, on institutional actors to be able to address what is unsustainable for those who are most impacted. So amen to your point. And I think that we can learn from, I think, what's been happening recently to think about how to move conversations by leveraging.
Well, thank you both. And I think we could probably have a panel on this question alone. But we have questions on other topics. Somebody is asking a question for Dr. Jones that Dr. Cohen just in the last few minutes made the point that people who have depression can find it difficult to engage in physical activity and other actions that help to prevent cardiovascular disease. So the question is the inverse true? If you are able to be active, does that help to reduce the burden of or to prevent depression and stress and anxiety?
Yeah, thanks for the question. I mean, I do think that it's not a unidirectional relationship. Certainly that when people can be active, they are able to engage in things that they enjoy, exercise, connectedness, other aspects of being able to be mobile and engage in activities. We do see that can be a protective effect for mental health challenges, in particular, the most common ones, like most prevalent conditions like depression and anxiety as well. And Dr. Cohen also mentioned sort of the connection with substance use. And again, that also is not unidirectional, contributing to both mental health as well as challenges with chronic conditions like cardiovascular disease as well.
Great, thank you. I think the more we learn about mental health and physical health, the more we see how intertwined they are. Question for Dr. Plesha. And this comes from Hattie Reese Hanley, who she was wondering if anybody from CDC could answer, in addition to the flu shot, is there any advice for cardiovascular disease patients on the RSV shots for those who are over 60? I'm hoping that from your position at ASTO, you may have an answer for Hattie Reese Hanley.
Yeah, I think it depends a little bit on what kind of cardiovascular disease history a person has. But I think there are many situations where, somebody would be at higher risk if they got RSV, where they would be great, where the RSV vaccine could be really, really helpful for them. The RSV vaccine, the recommendation for people over 65 is actually a recommendation that you discuss it with your doctor. And that's just because I think of the advisory committee wanting to be cautious about that vaccine in people who are older or have pre-existing conditions. So, probably I would say it's a really good thing for people with heart disease of any type to discuss with their physician or caretaker or care provider whether that would be a good vaccine for them.
All right. Thank you very much for that. Steve Sidney asked, what were the dollar amounts that were associated with the 1,500% increase in funding for public health and prevention in Indiana? And that's a great question, Dr. Sidney. 2022 state funding in Indiana for public health was $6.9 million. And in 2024, that will rise to $74 million. And in 2025, it will go up, it'll double again to $150 million. So 6.9 was the floor, 150 million is where it's headed in 2 years' time. Dr. Taylor, what are some of the most promising strategies that you've seen to attract dollars to investment in social determinants? I know you've done a lot of work on investment in housing security, for example. So if you can, in just a minute or two, what are some of the promising strategies that you see for bringing more dollars into investing in those upstream conditions?
Yeah, thanks, John. I think first question to ask ourselves is whether we want to be spending healthcare dollars on those things or we want those dollars coming from elsewhere. And that is a real live question with reasonable people, I think, on both sides of the debate. I think there are people who are strategic and say, look, it's really hard in this country to galvanize new resources to put straight into social service budgets. Doesn't seem to be that hard to put money into healthcare budgets of one variety of another. And so one way to go about this is to say, we're going to use Medicaid dollars through an 1115 waiver, or we're going to use other kind of healthcare dollars and target them at what we call social determinants of health or vital conditions. The critique of that is, well, do we really want to be ballooning healthcare budgets in that way? And does that inappropriately risk medicalizing what should be seen as social or community conditions or characteristics? And that's a real question that I think comes down to a political calculus about whether or not you can get it done outside of healthcare. In terms of like best buys, which I think is sort of what your question was gesturing at, what tends to happen is people ask what has the strongest evidence base. That evidence base is very much shaped by what NIH has been interested in funding research on. But I'll tell you, some of the best buys continue to be permanent supportive housing for people who are chronically homeless or have complex medical needs, medically tailored meals, especially for over 65, universal pre-K. So they kind of skip across different kinds of social investments, but there are some best buys out there. I would just say we should always approach that literature with a bit of a grain of salt, one of which is like what NIH has been interested in funding. And the second is the kinds of questions we've brought to social services or vital conditions are often like, what kind of health benefits do we get? Which is appropriate for those of us on the call who consider ourselves health policymakers. But sometimes we get null results on these findings and people want to kind of discontinue the program or chuck it out entirely when those things could be producing other kinds of benefits. It's not ROI to the healthcare sector or to your local hospital or insurer. But, like universal pre-K does more than avert healthcare costs. It does all sorts of other good stuff for our communities and for our kids. And so I always just caution people to look at that literature somewhat scrupulously in that respect.
Thanks. And I think you just sort of alluded to what a lot of us who do care about improving health outcomes for everyone often face, and that's the wrong pocket problem. That we are happy with a return on investment that's measured in additional years of life lived and additional health. And many people are looking at different metrics when they're making decisions about prioritizing the use of resources. So how have you seen anything, and this is for anybody now, any of our speakers, in the areas in which you focus, have you landed on any ways to measure and then to communicate returns on the investment of dollars in upstream interventions that resonate with people who prioritize metrics other than additional qualities, for example?
I'm happy to take a first swing at this one, John. So,
Please.
The wrong pocket problem is something that I've spent a lot of time thinking about and being concerned about. The way that I tend to think about it is the wrong pocket problem is the problem that exists when one sector makes an investment in something and does not recoup the full return on that investment. it's closely linked to the idea of what a public good is. And so my colleague Len Nichols and I actually devised a financing scheme for communities to make investments in these kinds of upstream or public good-like investments in social determinants of health or vital conditions. And it really rests on the idea that you have a community coalition of stakeholders who may come from different sectors, certainly from different organizations, and importantly, often competing organizations. So if you have two hospitals in town, or you have a couple insurers who are taking part of the populace, the kind of model that we laid out brings them together at the table, sets up a conversation about what local priorities are, and then can actually do price assignment amongst those stakeholders using a little bit of economic theory, so that you don't run into this problem where everyone in town knows that we need some additional sidewalks on this busy part of the highway. And yet one hospital looks at the other and says, like, well, I'm not doing it, you should do it. And the other one says, well, I'm not doing it, you should do it. They're stuck in that stalemate because for any one of them to bear the full cost doesn't make sense. But sidewalks are generally public goods. If the investment were to be made, both of those hospitals would benefit. So I would just direct people, if they're interested, the model is called the collaborative approach to public good investment. I can drop a link in the chat, but
Right.
we designed this model and we've implemented it. It works, and it kind of gets around exactly what you're trying to describe.
Great. Thank you. And Chris Jones, you referred to the critical role of ACEs in setting young people on course for either good or suboptimal health. Some of the interventions to prevent or reduce ACEs cost money. What have you found successful in the way of arguments for making those investments?
Yeah, I think much like Dr. Taylor, I mean, it's trying to make that connection back to some broader structural issues, larger policy issues, and the payoff for those things. So how do we look at interventions that set families on a positive start? Or how do we help kids throughout early development in particular make those investments that put them on a positive path? And a lot of that is funded through many discretionary programs. It's not inside the healthcare system. So it is always a struggle to find sustainable, consistent funding. But the research is, pretty clear that if we can reduce those early risk factors or strengthen those protective factors, we can have a positive impact on mental health, substance use, suicide, chronic conditions, leading causes of death. And so I think we're sort of in a nascent stage of figuring out, how do we look at Medicaid, alternate payment models, other approaches that are trying to incorporate social determinants, other upstream programs or policies that are outside of the healthcare system, to make that value proposition, that it is a worthy investment, that in the long run you do save money, but most people are not thinking in the long run, they're thinking in the short run. And so I feel like it's just a constant conversation that we're trying to cultivate advocates and champions for carrying that message, and then finding the right partners to test it out. We're having a meeting at SAMHSA, just a small technical expert meeting next week on the issue of alternate payment models in substance use prevention, because so much of what is done through a totally different system in communities outside of healthcare. And we want to figure out how do we get to a sustainable path? Because we do think it is a worthy investment, but we have to do the research to demonstrate that. And we need to think about, to your point on measurement, what are the measures that would be used to document impact? Because the health outcomes that people are often looking at are way distal to the interventions, right? So what are the proximal outcomes that people are willing to believe will lead to those longer term outcomes? So it's an uphill battle, but one that certainly we are working very hard to create more dialogue around and engage more champions.
Well, I'm glad you're having that meeting. Appreciate all those good points, and we'll be interested in hearing what comes from that meeting. Want to welcome Mayor Martha Guerrero to the conversation now. Welcome her back. Thank you, Your Honor. I have a question now from Christian Myers that Dr. Plesha, you may be, well, I'm going to tap you first to answer this, see if anybody else wants to join in. But Christian asks, how can trust be built between payers and state government organizations? Yeah, and that's a challenge. You're on mute.
I didn't mean to hesitate because I don't think it can. I was just trying to think of some good examples. I mean, I think that, you know, payers work with state government organizations on a lot of things. And, you know, one of the things that we're facing right now this fall is this, you know, concern about potential infectious diseases, COVID, RSV, and fall, really, you know, potentially overwhelming hospitals. And that's something that I think a lot of state government organizations are working very closely with payers and healthcare systems and others just to really think about ways that we can be as prepared as possible for that. And, you know, I think there's a wide range of other things. I think a lot of state government organizations are very interested in working with payers on issues where we want to make sure that there are good insurance products for people. And so, you know, there are many aspects of cardiovascular disease, for example, where we want to make sure that preventive services are well covered and a variety of other things. So, you know, I think it's a matter of kind of choosing the topic. And I think on most of these things, you know, if both, you know, particularly if parties are willing, if payers are willing to come to the table and discuss things, I think the state government organizations would be delighted.
All right. Anybody else want to take a swing at that? All right. We'll move on to the next question. And I'm going to read this one. It's a longer question, and I think this is maybe first for you, Dr. Manchanda. It's the question comes from Dr. Sunita Dodani at the University of Illinois, Peoria. And she asks, health inequities become visible as soon as a patient enters a hospital or a clinic. However, when doctors see patients, the major thrust is on the clinical or clinically visible problem, and not much attention is paid to understanding the social determinants that may be at the root cause of the problem. How can we, as clinicians, prepare ourselves to be mindful of health inequities in clinical settings? That sounds like what you work on every day at Health Begins.
Thanks, John. Yeah, I appreciate the question. Briefly, first, I think what we found to be really helpful in engaging those in healthcare to understand, identify inequities, and then think about how to play a role in reducing them, particularly healthcare inequities, is to start by characterizing these inequities accurately as harm, to understand these as harm events. These inequities are experienced as harm for individuals, and disproportionately some groups of individuals compared to others. Harm is something that healthcare gets, and is essentially very connected. It's part of our mission to be able to identify, prevent, and mitigate harm. Second is, in terms of the inequities themselves, understanding what the root causes are, as the questioner kind of implied correctly. It's important to understand what's contributing to or driving those patterns that we're seeing, those inequities among subgroups. And this is where, in addition to institutional factors like things that we do in our healthcare system, ways in which our institution is set up, do we have is the way that we structure our clinic hours impacting these inequities, for example. There's a lot of factors within the institution that are important to identify, as well as other social and structural drivers as well. So that's a key part of it, identify the drivers of that harm. And the last part is to really go back to, I think, the really great insights that Lauren, you were sharing, to recognize that as before we start to articulate our role in healthcare, we have to address, I think, this fundamental psychological trap that a lot of folks in healthcare on the front lines see manifest in policy conversations. For frontline practitioners, it's impossible to extricate somebody's patient social needs and what to do about them from the whole person that they're caring for. And then to say, oh, that's we'll wait for somebody else to take care of that. Let me only address that. It's possible. We've tried it, but it's at least a moral injury and ineffective care. So instead, I think it's important to be able to walk and chew gum as we talk about these issues. In other words, stipulate that at a policy level, healthcare systems should not be the sole or the primary mechanism to address unmet social needs in our communities and for our patients. That's something that the social sector and public health and policy needs to address. If anything, we need to regulate and control the cost of healthcare to be able to free up more funds to invest in the social sector and the public health sector to address unmet social needs and public health needs. But at a clinic level, it's also true and necessary to, I think, embrace as clinicians and in healthcare that it's our job as frontline caregivers, it's our job to make it easier for frontline caregivers to be able to more easily identify when an unmet social need is impacting that person's health or their care, and then to be able to understand how to connect that person to the appropriate resources to be able to help mitigate the impact of that social need on their health.
I remember, Rishi, and maybe in your TED Talk or in another setting, you're describing a patient with whom you worked who saw you after seeing a number of other clinicians, and she had long-term persistent respiratory distress, and you determined that the specialist she really needed was a housing advocate.
And a community health worker or promotora in that case. That's right. Yeah. So I think that story and probably the questioner and many others who are in healthcare and do have frontline experience are very familiar with stories of how we bear witness to the unmet, the downstream consequences of unmet social needs and upstream challenges, and the differential impact that it has on communities, which is why it's showing up primarily among low-income Brown and Black communities in patients. So I think it's important for us to be able to state that clearly, that healthcare has a role. Providers, we all have a role to be able to better identify when those needs are manifesting in impairing somebody's health or the care they receive, and that we have a role to be able to, within our job as those who aspire to provide whole person, high quality care, we have a job to be able to better understand how to address those needs in partnership with the social sector organizations. It's just part of what the highest quality care needs to look like. And that we can do that while also supporting efforts as caregivers to support those efforts at the ecosystem level, at the structural level, to be able to address more and provide more resources to address those issues outside of healthcare. We need to be able to do both and avoid a kind of a taste great, less filling debate about whether or not it's our job in healthcare to address patient social needs. My patients don't have the luxury of waiting for me to determine whether that's something that is appropriate. They need that support, and it's our job to figure out how to best support that in the same way we do for behavioral health and mental health. We have to be able to connect with others who can provide social health resources without co-opting them.
Very good. Thank you. Mayor Guerrero, some of the things that you're doing in West Sacramento and some of your fellow mayors are doing in other communities are simultaneously improving people's blood pressure, empowering them to improve their blood pressure and their mental health at the same time, and to help prevent or reduce depression, for example. How do you see, what kind of reaction do you get from people when they come out? What do you hear from people who maybe you help them get up off the sofa and come out and become more active, take more control over their own life course and their own health? Do you get response from them? Do you get feedback?
I think as long as you open up the opportunities and make them accessible, it's as far as what Dr. Manchanda was referencing is seeing it, seeing the access at their level, in their language, directly connecting them to where, for example, our YOLO food bank distributions. We have UC Davis students who are providing free blood pressure checks and giving them more information about access to healthcare services, including like our Welcome Baby program. We have an increase of Spanish-speaking families in our city who are availing themselves of a nurse who goes to their home and provides a continuous checkup, educating them about mental health resources, and just providing the other resources and education on where to access them after they are done with the Welcome Home baby checks. That's something that I think we needed to work on, especially after COVID, where there was just some fear and mistrust of a healthcare setting that may not be healthy. It may be dangerous, that people were afraid that it was COVID. That's when we had to open up our healthcare settings and open up tents to separate those that had COVID and those that did not. So, reintegrating them back into the healthcare setting, doing Move with the Mayor as well, where we had May is Bike Month, and having healthcare mental health program, educating them on access to mental health services. So partnering with them, and now also with our school settings, working with the county in partnering to get access to mental health services with our unique Mental Health Services Act program, making sure that youth who are still currently struggling as a result of remote learning, distance learning, now that they are having a hard time just being able to acclimate back in the classroom, learning, they're behind, and the stress that they experience from that. So making sure that youth and teachers, even through their physical education programs, are tapping all the mental health resources or a counselor. Also with the city, we've expanded the number of programming in our Parks and Rec department, so it's accessible in the high schools and in locations where youth have not traditionally had an easy time. So we're trying to open up more venues for our youth to be able to have resources so that their social emotional needs are addressed.
All right. Thank you. We have a question, Mayor Guerrero. This may be another one best suited for you. It comes from Katie Adamson of the Y USA. And she asks, how do we utilize out of school time for this kind of programmatic work, recognizing how stretched schools already are?
Yes, in West Sacramento, the school districts have partnered with the YMCA for extended care. But we also noticed that parents are now remotely working. So they are able to take their youth home after school. So depending on, for them, what's accessible for them to access, we can do it in combination with the YMCA programs. But through our Parks and Rec department, we have increased a number of programs for our youth. So it's going to be rock climbing, basketball. Our West Sacramento Police Department has weekend football clinics, and they partner with Invicta to, regionally, so that we can get all the youth who would like to participate on the weekends as well. So yeah, out of school is, I think, incredibly important, where we have not only athletic activities, but we have art classes, dance classes, and, just opportunities for them to understand in their emotional situation, how to express themselves appropriately through additional programming is what we've had in our Parks and Rec facilities. And so we have also VIA for the high school students, which is on-demand rideshare, which provides transportation for our high school youth if they would like. And during the summer, we provide free transportation for them, for those that have longer distances, so that they can access those programs during the summer months.
So I'm hearing that not only do you have programs in place, they are addressing both mental health as well as physical health. And one of the things that we've talked about earlier in this meeting was people being civically engaged, and the strength there, the civic connections. And I hear in your answer, that's a component of the programming that you're making available. So that's exciting. We have a question from Gwen Mays in Maryland. who asks, considering the link between heart disease and mental health disorders, how do we ensure that cardiologists integrate the two, mental and physical, during evaluations and ongoing disease management? And I want to start, Dr. Jones, with you on that. And then I'm going to expand the question and say it's not just limited to cardiologists. I'd like to hear from the primary care providers who we have here on the panel as well.
Yeah, thanks for the question. I think it's important. I mean, there's a broader effort across HHS and certainly within SAMHSA to better integrate behavioral health and physical health. And that can take many different forms, right? I mean, sometimes it may be co-located, sometimes it may be upskilling and training, or you have a psychologist on staff, or you have just working relationships with people who could be referred out. I mean, there are other models like community behavioral health, certified community behavioral health clinics, which are intended to be like sort of a one-stop shop. And there have been efforts to try to improve behavioral health within federally qualified health centers who are providing lots of different types of care, and maybe not, cardiovascular specialty care, but certainly many different types of care. So I think there are different approaches, but, just one thing is that we often find among many providers who haven't been well-versed in substance use or mental health that there's just a lack of self-efficacy or comfort in having those conversations. And then even if there's interest, not always like, okay, so what? Like, what do I do, right? And so I think having those connections, looking at collaborative care approaches, depending on where people are practicing, can be a way to provide a backstop for somebody to feel comfortable that you could add a fairly straightforward screener to the intake when the patient is asked a lot of other questions about their medications and any changes in their health. There are very short screeners that can be used to identify, do we even need to have just a conversation, right? Not diagnostic screeners, but something saying like, how is somebody's well-being or mental health going in the last couple of weeks to prompt that conversation. We do provide a variety of resources at SAMHSA, both on the mental health and substance use side for clinicians, different trainings that are available to help bolster confidence in having those conversations. So those are resources. But I think we have to really look at more of the broader systems perspective and recognize that for far too long, even mental health and substance use have been siloed, much less physical health. And there is an opportunity to really think about how are we building systems that allow patients to get the care they need without having to navigate 15 different doctors' offices. And so obviously that's aspirational, but I do think that's an important way that we should be thinking about how we're deploying resources, how we're thinking about payment approaches to look at that integrated systems approach.
So thanks, Dr. Jones. There's the sort of 30,000 foot level perspective on it, looking at the big picture. We have a couple of family physicians with us right now. So Dr. Manchanda and then Dr. Plesha, how does it look from the front line, the primary care provider's perspective?
I'll be brief only because I think Dr. Jones said all the talking points that I would have said, so far better than I could. I really want to echo, I think, the collaborative care models, the power of that, the work that SAMHSA and others, as Dr. Jones, you mentioned, has done to be able to help lead the understanding of what integrated behavioral health and primary care and healthcare can look like, especially primary care. The only thing I kind of add and then tee it up, Marcus, for you is one thing that I think about in the primary care space is the model of community-oriented primary care and how analogous in some ways that is in spirit with the vital conditions kind of framework, in that it's centering community and not healthcare as the place to start thinking about where change happens and how it can happen. In this regard, there's a lot that we're often expecting of primary care clinicians and healthcare in general to be able to address social needs, screen for this, address behavioral health, and it can feel overwhelming. One thing we've seen consistently is the power of bringing in people with lived experience, patients and members in the community and organizations in the community, in not just to be advisors, if you will, which is powerful, but also to be kind of drivers of the change, right? To help be the fuel to support the practice transformation, the changes that happen in the practice. we don't have to assume that all this change has to be driven exclusively from within. We can see improvements in behavioral health integration time and again when we bring in patients, people with lived experience, and community organizations to help share their wisdom, but also drive and support some of the efforts to transform what's happening inside the walls of the clinic. Marcus, I welcome your thoughts.
I'm not sure I can add a whole lot. I think that's a good synopsis from the last few folks of kind of where things are. And I mean, I think I'll add, we ask a lot of primary care physicians, and it's good to be cognizant of that. But I also think this is why people go into primary care, is to really try to delve into these issues and make a difference. And so I think we shouldn't stray from asking them again and pushing, because I think that's what they want to do.
Well, thank you both. We have another member who has a brief update to share with us, and then we need to transition at the bottom of the hour. So I'm not even going to attempt at this point to summarize all of the questions and answers that we've covered here. That would take too long. But I do want to thank the members and stakeholders who are participating in the meeting for the questions that you provided, and the questions were great. So thank you very much. Great continuation of the earlier panel discussions. And now I want to thank Chris Jones, Lauren Taylor, Martha Guerrero, Marcus Plesha, and Rishi Manchanda, all for participating in the panel discussions, and then for participating now in this Q&A session. Thank you very much for all that you've shared and how you've enriched our day.
Thanks, John. Have a good one.
Thank you. Vascular Nurses Association had to leave, so she said she wants to share that PCNA, as part of their strategic plan, has a major focus on health equity across the organization, and they address health equity in all of their education and advocacy efforts. Specifically, they've partnered with the Association of Black Cardiologists to deliver a health equity virtual conference and legislative update for the past 3 years, and they're looking forward to doing more. So with that, I'm pleased to transition to the annual business meeting portion of our meeting. It will be fast, very fast moving, and we will follow the business, including the election of new directors for the National Forum Board, with awards. So the National Forum Awards will be presented shortly. So please hang on with us.